We have several unmet needs for the clinical management of type 2 diabetes. With regards to diagnostic classification, we still have a lot of work to do because type 2 diabetes is quite a heterogeneous condition. And for example, some people have more impairment in beta cell function, whereas others have a mix of beta cell dysfunction as well as more important insulin resistance, etc. So, and clinically, it's a little bit difficult at this point for clinicians to have they don't have the tools to help them sort them out. And I'm convinced, although we don't have quite the proof of that the phenotype, the exact mechanistic phenotype of type 2 diabetes might determine the best course of action for prevention and treatment of this disease. And this is really, really poorly, if not exploited at the moment clinically. We're still focusing a lot. We have a glucocentric view of the management of type 2 diabetes, but we need to step back a little bit, look at the pathophysiology and try to rework a little bit the classification or understanding of the progression of this disease as well as its complication, and perhaps try to define better tools to categorize the different management. Right now, in Canada at least, we have at least 9 oral agents approved, now 10 class of oral agents approved for the treatment of type 2 diabetes. We have several insulins in addition to that. It's a mess completely especially for generalists to try to pick up the best initial treatment and the best combination down the line of treatment to treat this complex disease. So hopefully by characterizing a little bit more carefully the exact pathophysiology of each individuals, we might be able to skew a little bit the choice of the class of medications that we may employ early on, and of course also to determine the benefit and to what extent it will be beneficial to change this or that lifestyle in that particular individual.